Welcome to Focus on Health, a series of educational programs highlighting health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. Today, I welcome Dr. Mark Edney, a very frequent guest on Focus on Health. You are the president of medical staff at Peninsula Regional Medical Center and also a senior physician, urologist, of course, at Chesapeake Urology, which has offices in Salisbury, Seaford, and Berlin. So welcome back to the program.
Thank you very much. Pleasure to be here.
And I know what you wanted to do today was give an update again on COVID-19, but from a more regional perspective in terms of how PRMC is doing and also how it's been faring so well compared to many other hospitals. So I'm going to ask you, we'll start off by discussing the current status of operations at PRMC with regards to COVID-19.
Yeah, so things are moving along very nicely at the hospital. We are able to sort of take down a lot of the extra capacity that we had built. We were pleasantly surprised that we didn't end up needing much of that extra capacity, but it was there if we did need it. And so we're slowly, you've seen the tents come down as you drive by the campus. And as of today, the special ICU that was built in the basement of Hollowell, which used to be a conference space and some office space, that was turned into a 40-space ICU. As of today, that's empty, which is phenomenal news. We are going to keep that space set up as an ICU, at least through the fall and into next year, just in case it's needed in the near term. But you know, thanks to the absolute expertise of our engineering team, it was built in a way that the walls can be put back up, and it can actually, the space can be turned back into conference space with the ability to take the walls down and rapidly turn it into an ICU again if need be. So it was kind of built in that adjustable fashion. But the good news is that that space is empty. We currently, as of today, have 22 COVID positive patients at the house, in-house, and that's significantly down from the peak back at the end of April, beginning of May, when we had mid-60s, 65, I think was our peak. So we're down to 22 and we're continuing to decline. So we're seeing great declines in numbers. What you're seeing in the community in terms of testing numbers, those continue to rise in some areas. A lot of that has to do with the spread of the availability of testing. So as more people are tested, you're going to see more cases. But really the best barometer of the impact of COVID on our region is asking the question, what percentage of people who are getting it need hospitalization? Either just medical support in the regular hospital or intensive care support. And the answer to both of those continues to be that those numbers are continuing to decline. So that's all great news from a hospital perspective. I wanted to make note, and people should be aware, as we start to get past our surge that we had and look back on both the things that went well and the things that we may change differently if this comes around again. Our hospital, our medical team who took care of the sickest COVID patients, the internal medicine doctors and critical care doctors and emergency room doctors, are starting to get some national attention for the success that they had in dealing with COVID. The NIH actually contacted the hospital a couple of weeks ago because our data is now starting to be submitted. And they said, what are you doing right? Because your numbers are absolutely phenomenal. It turns out that our mortality rate was 100%, in some cases better than some similar regional health systems in the area on the Eastern Seaboard. And that success, and I've talked to the primary players on our team and asked them, you know, we've been very successful, super successful in treating this disease when it presents to us. What do you attribute that to? And it was a few different things. We had a team that was very aggressive very early on with not only identifying COVID positive patients before we had widespread testing. It turned out there were some clinical indicators of the virus, and largely it was CT scan appearance. So we were getting a lot of CT scans early on, but there were certain blood tests that suggested the patterns. They weren't blood tests for COVID, but they were abnormalities and other things that you can test for that suggested the presence of COVID. And they were going on that clinical testing and going on hunches. And then we very early started to segregate the people that we thought were probably COVID positive, keeping them separate from the rest of the population. So that recognition early on of who was COVID positive and who wasn't before we had widespread testing, but the ability to make algorithms and protocols. And so you make a standardized approach when you have someone comes into the hospital. These are the things we do. These are the tests we order. These are the treatments we order. And that protocol changed on a daily basis, sometimes 2 or 3 times a day. And again, thanks to this team, not only paying attention to what was going on in our hospital and in our region, but they were also in contact with other hotspots in the country. So you had things going on in Louisiana, in the New Orleans area. You had the Detroit area in Michigan. So folks on our team had contacts in those hospitals, and they were calling them, saying, what are you seeing? What are patients responding to? What are you doing differently? And every time they would get a new piece of information, they would change our protocol to update it and implement it and make it better. And so hats off and kudos to the very dedicated physicians, the intensivists, intensive care unit doctors, the internal medicine doctors, and the ER doctors in particular at PRMC. And there's a lot of them to mention. I don't want to start naming names because I'll miss them, but they are a phenomenal group. And achieved some astounding results for our region with respect to our outcomes. When you think about our service area as a hospital system, it's about 500,000 people. When we talk about our catchment area, that goes up into Sussex County, Delaware. We've got Wycomico, Dorchester, Worcester County, and Somerset. That's our primary catchment area, 500,000 people. And out of that 500,000 people, given the wave of virus that our region experienced, it was less than 300 people that needed to be hospitalized for COVID disease. I believe the number was somewhere around 280. And so 280 out of 500,000 people, just for perspective, COVID continues to get a lot of press, and it's important to be aware of it, but it's also important to look at the actual numbers and really put this in context as we talk about moving forward and how do we as a society emerge from this, and what protections do we put in place, both in the workplace and out in the communities and in the schools in the fall when we talk about going back to school. It's important to know what the actual numbers were, and those were our actual numbers. Total deaths at PRMC from COVID, 30. And so again, with respect to the number of people that were affected and the size of our population, especially given the particular issues that happened in the poultry industry, we knew there were some hot spots in the poultry industry locally, both in Sussex County, Eastern Shore, Virginia got hit very hard, Accomack County in the poultry industry. So even given those hot spots, that mortality rate for what we were experiencing was astounding. It was very well done, and really the best we could hope for. And it's thanks to the very talented team of doctors we have at PRMC.
As usual, just very impressive, and some excellent information and statistics has led me to some other questions. What is the estimated overall mortality rate in the U.S.? Is it as high as it's being made to sound in the media? It's
interesting. It's not, and it's lower than originally. If you remember, this number keeps getting ratcheted down. If you remember back in February when we were starting to hear this virus come over from China, and it started in the West Coast in Seattle in that nursing home. And the early sort of projections and what you kept hearing trumpeted in the media is, could the mortality of this thing be upwards of 4, 5, 6%, which is just a disastrous mortality for a virus like this. And then as we started to experience it and see the impact in our local communities, that got ratcheted down to less than 1. Most of the data that I'm seeing in the medical literature and in the experiences from around places that have dealt with it, it's less than 1%, probably on the order of 0.4, 0.5, 0.6% mortality. Which is still higher than the seasonal flu, which I believe is about 0.1%. So still a bit higher, but not orders of magnitude higher. It's a bit higher. And we know a lot about, and we've learned a lot about the underlying conditions that put you at risk for getting the sickest if you get this virus. And it's still true that a lot of people get this virus and don't have symptom number 1. They have absolutely no idea that they have it. Another set of people will get it and will feel like they've got a bad cold. They get the muscle aches, they get a fever, you have a cough, you feel lousy for a few days, and then you recover. So that's another whole big subset of people. It's only the tip of the iceberg of the folks who end up needing hospitalization, and even a much smaller percentage of those who have to go into critical care and have respiratory support. So again, putting these numbers into context is critically important. But the medical conditions that we've learned about that expose people to the highest risk of getting very sick if you get it, obesity turns out to be a big one. We're seeing that across populations, and there's something just independent about obesity. It's not even the underlying conditions that can go along with obesity, although those are important, but having a high body mass index is a huge risk. Hypertension is another one, and and,
Diabetes is
and finally diabetes. Absolutely. So those are the big risk factors. And for folks in the population, of course, age. You know, the most of the mortality is people older than 60 years old, and of that group, most of that is greater than 70 and greater than 80. So the older you get, the higher risk you are from not responding well if you get this disease. And so again, that's very useful information with respect to, as we as a society sort of move through this and learn to live with COVID, because we're going to have to live with it for a while until hopefully there's a vaccine. How do we protect those most vulnerable? And that really becomes the issue. And so it's folks with those underlying pre-existing conditions, and it's our senior citizens that we really have to figure out how to continue to protect, to make sure that we're being, going about business as safely as possible.
right, and that's why nursing homes and a lot of retirement facilities are on lockdown. Just don't want to take the chance of anyone bringing it in because of that. The other question I wondered about, because I've heard asthma isn't such a risk factor as people thought, because this disease does seem to attack the lungs and many people need to go on a ventilator. What about emphysema? Does that put you behind the eight ball at all?
Again, those underlying pulmonary conditions, you would think that they would, because this is essentially a pulmonary condition, although it does have gastrointestinal effects. You hear about diarrhea and some other things, but it's primarily a respiratory illness. You would think that they do, but we just haven't seen that borne out in the literature as sort of independent risk factors for getting sicker with this disease. So it's an interesting question, but so far I haven't seen that come out.
And you mentioned some lab tests that your doctors were doing fairly early on. I've read some literature about coagulation issues. Is that one of them?
Absolutely. So you get coagulation panels, and there's a particular test called a D-dimer, which has to do with the body's clotting mechanisms, and that would oftentimes be elevated. And one of the side effects, again, I'm not a COVID disease expert, I'm a urologist, but having sort of been aware of, in talking to my colleagues in the hospital who treat this, and just seeing what's going on around the world, particularly in young people, one of the really disastrous potential side effects is clotting disease and strokes, and other health effects that you can have of problems with your blood's clotting mechanism. So that absolutely was one of the early tests that was obtained. And a lot of these folks now are put on blood thinners when they come into the hospital to prevent just those sorts of outcomes.
Well, I know you mentioned how our numbers are going to go up in the region because more testing being available. What about the antibody testing? Where are we with that? What's your thoughts on that?
Fantastic question. So there are more than 100 antibody tests that are now available that have been produced by industry and are now out into these private laboratories. The issue with them, by and large, is there are two things that you want in any laboratory test. You want it to be positive when the disease is present, and you want it to be negative when the disease is not there. And that's called sensitivity and specificity, and those are the fancy words. But you want the test to perform well. And the problem is that the performance of the tests that are out there right now aren't exactly where we need them. They're pretty high. Ideally, for a really good test, you want your sensitivity and specificity to be above 90%, ideally in the 95% range. And for some of these tests, the sensitivity is still in the 70, 75%, 80% range. And so in other words, what that exposes you to is the risk of either false positives, meaning your test came back positive, but you actually don't have it, or a false negative, meaning you actually have it, but the test just didn't tell you that. And so those are the problems so far with all of the tests that are out there. And compounding this potentially is there are now about to be a raft of in-home tests that are being put out by industry. So a bunch of them have been cleared by the FDA, but the concern is that they're going to suffer from these same deficiencies. And so potential for false positive and false negative tests. And they're also quite expensive. The home tests, it can be upwards of $150 or $200 a test. So be careful before you spend your money on a home test. Know what you're getting into. By all means, if you're willing to accept the risk that you may get information that's not reliable and you're just interested, go ahead and do it. But also understand that there is a risk of either a false positive or a false negative test with these home testing kits. But ultimately, the antibody testing, once it's refined, and we just need time to do the proper studies and to refine the tests appropriately. Eventually, there will be antibody tests with 95% sensitivity and specificity. That research is ongoing. We'll get there. And when we do, that's going to be the best way to really understand what proportion of society was affected by this thing. How many people had it, didn't know it, or had it and had mild symptoms and didn't get the virus test at the time, but are now potentially immune. So we'll be able to start to answer all of those questions over time with these antibody tests.
Right, because that would be very helpful if it was a good response antibody-wise, where you couldn't get it again because that's
Yes,
part of the herd immunity concept.
exactly.
What about reportability? If I do a home test and I come back positive, am I required to call the health department, or how are they going to track all that?
That's a good question. I'm not sure what the current policy is. I don't want to misspeak.
Right.
So you would think that that would be something that would be reportable. Certainly, if you have a positive viral test, I believe that you're required to let the health department know. But in terms of an
Mm,
antibody test, I'm not sure there's been attached to that any responsibility to report. But again, I don't want to be quoted because I'm
right,
not
right,
sure.
right.
I'm
Now, I
not sure
meant
what
the
the policy
viral
is.
test, wouldn't
Yeah,
you have to report that or whatever?
I
But
believe that's a reportable event. Yeah.
mhm. Yeah, so many questions really, but I know one thing you wanted to talk about to help people understand that as a healthcare system, we are starting to get back to more normal now. And you run a urology practice or practice there. And what are some things that doctors' offices are doing to make it safe for people to come back and get their regular checkups and see the doctor if there's a problem?
Absolutely, Mary. This is a critical question to start talking about right now. There was a group of doctors who wrote a letter that got a lot of press a couple of weeks ago, wrote it to the president saying, basically making the point, we're on the precipice of a mass casualty event with respect to the health status of all of the people who put off health care because of this virus. These health problems didn't go away. And in fact, a lot of times they were silently getting worse without people's knowledge. We're starting to hear stories all the time of people who had some chest pain, stayed home, ignored it because we were mid-COVID, and then 4 weeks later had a severe heart attack and came into the hospital and were much sicker, perhaps, than they would have been had they come in with that mild chest pain. And so we're seeing that play out across specialties. And so it's critically important. We have made it safe in these offices. Variety of different things we're doing. We're spacing out the waiting room. We're for procedures. So we have an ambulatory surgery center at Chesapeake Urology. So half of the building is procedure oriented. The other half is office visits. We've got separate waiting rooms. We're spacing those waiting rooms out. We're having, family members wait in the car, and we're making contact by phone afterwards to kind of reduce, crowding in the waiting areas. Everybody's wearing a mask. We're, washing our hands, doing everything that we need to do to reduce any chance that anybody's going to be harmed by any virus that may make it into our building. All of the staff at Chesapeake Urology get tested on a monthly basis, whether they're symptomatic or not. And so I went through a round of testing a couple of weeks ago, both the viral test, and we're on a research protocol for a newer antibody test that's maybe one of these newer, more specific tests that have better performance, but we're part of the research, so we don't know yet if this antibody test performs better. But we as all of our staff members are getting tested on a regular basis to make sure that should it rear its head, even in somebody who doesn't have symptoms, we're going to find it and be able to send that person home until they can recover, and keep our patients safe. And I know a lot of other offices are doing the same thing. So lots of different measures to make it safe. And we've communicated. And the most important thing with this is for these offices, and our office has done this, to communicate with your patients. Let them know what you're doing. Let them know that it's safe to come back. Let them know exactly how you're making it safe for them. And we've seen that our patients are happy with that communication. And our offices, my schedule is largely full now. So I'm seeing full days of, 15, 20, 25 patients, come back in to get the stuff that they didn't get done a month or two ago that need to be done. And I would encourage anybody who is sitting on the sidelines and waiting. It is now safe. We have implemented all of the CDC guidelines here locally. You got to come back in and take care of your health. It's safe to do it, and you need to do it.
Absolutely. I know I had a doctor's appointment. I had an eye appointment a few weeks ago, and I felt very safe. I mean, there was protocols in place for cleaning. I had to wait in the car as the patient, and they would call me when it was my turn to come in. And I thought it was very well done, and I felt very safe in that way.
Mm-hmm.
So I think things have really moved along nicely in terms of making people feel more comfortable about coming back into the doctors or going to the ER. I mean, to me, the hospital might be one of the safer places to be because they are just so in tune with all the disinfection and all those procedures that have to be done.
Yeah, absolutely. And we're talking about offices right now, but I also have been intimately involved in opening up the operating room at the hospital again. And we've done that. We ended up, keeping count of the cases that were backlogged. There were a certain number of, quote unquote, elective cases that were put off during this 2 months where we really had to shift downward. There were about 420 cases of things like hernias and gallbladders that weren't emergent but needed to be done, about 420. And we've now, as of last week, started to go full speed to kind of ramp up to get all of those cases done while we're continuing to take care of the things that come in tonight and tomorrow that have to be done. And so we've talked about extending hours into the evening. We've talked about doing some cases on Saturdays. And so we are expanding our capacity at the hospital. And again, I want to reassure everybody, we have taken all precautions to make sure it's an extremely safe environment. So if you've been putting off surgery, talk to your surgeon's office. It's time to get back in and get that done.
And also screenings are so important, whether it's mammographies for women or colonoscopies,
Absolutely.
things like that are still really important. The other thing I've read about we're worried about is vaccinations. A lot of kids not getting their regular vaccinations, that got put off as well.
Mm-hmm.
And I know one thing you wanted to talk about is we've heard a lot in the news about this exaggerated immune response that kids seem to be getting, but that again is a very small percentage. So maybe reassure us about that.
Sure. So this was some news that came out of New York. I believe there was a cluster of children who had tested COVID positive, who developed what's called Kawasaki disease. And again, speaking as a non-pediatrician, I'll tell you what I know about Kawasaki disease. And essentially, it's an exaggerated immune response. And Kawasaki disease has been known about in kids for a very long time. It's a very rare disorder, but it's an exaggerated immune response and oftentimes responds to steroids and some other treatments. But these kids who were COVID positive were developing a fairly significant form of Kawasaki disease. It has a variety of different sort of ramifications, but the Kawasaki disease did respond to steroids, as it usually does. But it turns out this cluster of kids was a very, very small percentage of all kids who got it. And of all people who get it, kids are a tiny percentage. And so this is one of those things that got really amplified by the media. It probably got more attention than it needed. I mean, nobody wants anybody to get Kawasaki disease, but the kids who had got it were a very small number. The vast majority of them were very successfully treated with steroids. And so it ultimately wasn't a huge issue, but it's something to look out for if a child in your family or your community develops a COVID positive test. These are sorts of reactions that are worth looking out for. But again, the chances of developing an immune response similar to Kawasaki disease are very, very low.
Well, the problem is, I guess, it only took a few kids that didn't have a good outcome, and that's what we tend to focus on versus
That's
what
right.
is that as a percentage of the numbers. Because
Yeah.
kids generally have been shown not to really get COVID, or if they do, it's a fairly mild case, correct?
Yeah, so there's some really interesting science about that, Mary. And so a couple of large studies have been published in JAMA, which is the Journal of the American Medical Association, with respect to cohorts of kids who have been in hot zones, who have been exposed. There was a study out of Australia looking at about 15 schools, and this was through March through mid-April, so over 6 weeks in Australia. And starting with 16 kids in that school district who had tested COVID positive, they didn't shut down school. They continued to conduct school. And then they re-looked at their numbers at the end. And through 6 weeks, even having 16 positive kids who were then sequestered, but you think, well, the virus is here, it's got to be around. Only 3 additional children acquired COVID over that subsequent 6 weeks in this school. And there were no cases of transmission to the adults, which was a fascinating result. And so, whether there's something sort of less contagious, I think kids, there's starting to be science emerge that kids are just less susceptible to getting this virus. And there are a couple different potential reasons. Another study to support the fact that kids are less affected as a population was antibody testing that was done in Spain. So you remember one of the early hot spots was in Spain. And so they took a population that was for the adults, a hot spot, and they looked at the kids and they actually did antibody testing on the children. And they looked at the positivity rate for kids less than 18, and they broke it down by age categories. But the bottom line was, in a hotspot where kids were likely very exposed to this virus, single-digit numbers had tested positive for the antibody. And so, and it got higher as you got older, but 1-year-olds were 1%. And as you get up to 18, it was 3 or 4%. But still, 3% of 18-year-olds in a hotspot where the virus had just moved through, we're not sure why that is. And that's where the science is going to go, is to start asking those questions. Is it that kids have some underlying biologic immunity to it? And there are a couple different potential things there. Remembering that coronavirus is a new virus. However, coronaviruses aren't new. Okay, so coronaviruses cause the common cold. There are other types of coronavirus. And so there's some speculation that having had the common cold in the last year or two, a different coronavirus may confer some resistance to this novel coronavirus. And that's one possibility. Another possibility is that children may have an underdeveloped receptor for the coronavirus. And so what's known is that these S proteins, the fact that to the extent you've looked at all into sort of the structure of the coronavirus, the binding site of the virus is called a spike protein, the S protein. And it binds to a receptor in the lining of the respiratory lining to a particular receptor called an ACE receptor. And I don't want to go into too much into the weeds on that. But it turns out kids may have either underdeveloped ACE receptors or ACE receptors that just haven't matured enough to the point where they bind and hold on to this virus. So it may be that kids can be exposed to the virus. They just don't get it. Their bodies don't hold on to it. Another possibility is that they get it and their young immune responses by and large hit it so hard that it doesn't have time to stick around to generate those antibodies that are indicated once it sticks in your body for a longer period of time. Their bodies may just be clearing it immediately. So lots of different very, very interesting areas of science and research are going to go on to sort of try to answer that question. Why are kids seeming to do much better than adults through this? But that's what we've been observing, is that kids do not seem to be harboring huge amounts of this virus and passing it around and being asymptomatic. It's more likely that they're just not getting it, or if they're getting it, they're getting rid of it immediately for a variety of different reasons that we'll continue to figure out.
Yeah. And I guess on the other side of the coin, you have older adults whose immune systems aren't as responsive and get hit a little harder, among other things, those underlying conditions you mentioned earlier.
Yeah.
I guess the three major things people are looking forward to in terms of helping to keep flattening the curve and survive this whole thing is, everyone's hopeful for a vaccine sometime, more antibody testing or more, efficient, effective antibody testing. I know I saw Dr. Gottlieb from the FDA on the news one morning, and he was talking about they're developing a test that's 85% accurate, but it only costs $5. It could be easily given to a lot of people. And then for people that really look suspicious, they could go ahead and do the blood test for that 15%. And he feels like that would be a big step in the right direction for reasons you mentioned earlier. And then, of course, contact tracing is going to have to be implemented. So there's a lot going on, a lot of bright minds, I think, working on this.
A lot of very smart people. Yeah, the whole issue of the vaccine is really interesting. There's a lot of hope that a vaccine will be developed that works. There are three major American pharmaceutical companies who have vaccines in development, and a couple of them have started the process of mass producing their vaccine even before we have the results of phase 3 studies. Without getting too much into the weeds, whenever you study a new intervention, there are 3 different phases of research that it goes through. And the final phase is showing that it's actually effective in humans for the purpose that you're using it. And one particular right now is ready for phase 3 that's going to start in July. And this company has already started mass producing and will have 100 million doses by the end of the year, as long as the phase 3 studies support that it actually works. And that's been another challenge of doing these phase 3 studies, is as the virus starts to trickle off here, you've got to find a big enough population who's exposed to it, because if you're testing whether or not your vaccine works, you need to give it to somebody, and then you need a population. You're not sending people into COVID parties, but you need a population who is at risk for the disease, and then you need to study them and say who gets it and who doesn't. It's going to be harder and harder to find, we've put out all the hot spots, and it's going to be harder and harder to find populations with enough virus circulation to actually test to make sure that it works. So those will be the challenges that scientists will deal with. But the hope is, and we believe that we should start to have some of that data by the end of the year. And it would be great news to see if one of these vaccines actually works and we could start circulating it. And that would completely change things about how we're able to conduct our lives and in our businesses and get back to the life that everybody wants to get back to.
Right, I know. As we wrap up, maybe just take a quick moment to remind people, what are the key symptoms where they should call their doctor, and then, of course, the things we can do to help protect ourselves and prevent transmission to others.
Sure. So the key symptoms, there have been small symptoms that have come and gone from this list as we've seen a variety of different presentations, but the ones that are mentioned all the time, fever. If you've got a fever, shortness of breath, cough. Again, this starts off primarily as a respiratory illness. Fever, shortness of breath, cough, muscle aches. If you've got that constellation or 2 or 3 of those, call your primary provider, and it may be that you want to think about testing. There are some gastrointestinal complaints that we've heard about. So diarrhea, abdominal cramping, muscle cramping, those sorts of things. So if you notice those with or without fever, cough, respiratory stuff, again, that may be something that you want to have evaluated. So those largely are the symptoms. There's some more minor ones that I don't want to necessarily confuse people about, but those are the major ones really to look out for. Your other question was
about, what's the best way to protect yourself? Just remind people.
Yeah, absolutely. So the hand washing is big. It's interesting. We worry about surfaces, and there's been a lot of talk about how long does the virus live on this versus that, on metal versus plastic versus whatever. And it turns out that it does. Yeah, exactly. It does. At least in laboratory settings, it lasts for different amounts of time on different surfaces, ranging anywhere from several hours to even a few days on some surfaces. But interestingly, the epidemiology that's been done so far and the studies that I've seen, surfaces have not been a major source of transmission of the virus. The hot spots and the places where people are getting it in high volumes, it's person-to-person transmission. I mean, that is greater than 90%, greater than 95% of the transmission is person-to-person through respiratory droplets. And so really important, the mask wearing is important, especially if you're going to be indoors. A couple things about the transmission of the virus. So while we're on the subject, so the likelihood of acquiring it has to do with a few different factors. It's how close you are to the number of other people that are in a room, but there's a time factor. It takes an amount of time for you to be exposed to a sufficient amount of the virus to actually get inhaled. And this is biology work that was done a long time ago on influenza and other things. It takes about 1,000 viral particles in your respiratory system to actually become infected. So if you kind of pass someone who kind of has the virus and they happen to kind of breathe and you go through their breath cloud, regular normal breathing, people expel about 20 viral particles per breath. So much less than you would think. Now that's just breathing. We're not talking about coughing, sneezing, and the other things. If you're just breathing, a normal exhale is about 20 viral particles. So if you just happen to pass somebody who breathes and you go through their breath cloud, you may get 20 viral particles. That's probably not enough to get infected. But if you're sitting next to someone for 2 hours and they're talking maybe 100 viral particles per minute or something higher than that, you can see there's a time factor there. So shorter periods of time are better. The longer periods of time you spend with people, the higher risk of exposure. This is, again, if they have the virus. So this is where the masks really help. And so the mask is to protect everybody around you. The cloth masks and everything you're all seeing is to protect those around you. They're not protective for you. The N95s are the only properly fitted N95s are the only ones that are protective for you. The mask is to protect viral spread. So if you need to cough or sneeze, do it into your elbow. It's the coughs and sneezes into the room where viral particles can be in a fine mist and can linger in the air. So the virus doesn't transmit itself in the air, but it sticks to respiratory particles. And when you cough or sneeze, the vast majority of those particles kind of fall right in front of you. But there's a very fine mist that you can't see. It's sort of a cloud that's created in a room. And so that's where, if you are in a room for a significant period of time and somebody had the virus and they sneezed, if you spend enough time in that room, that viral particle cloud that are on the fine respiratory droplets, could eventually expose you. So I wanted to make the point that it's being indoors, being close to other people, and there's a time factor there, is the amount of time. So those are the principles that we need to use, is trying to space people out, trying to reduce length of time that we're together. And the more you can do outdoors or in open air circulation is the other variable there. The more you can have air circulation,
I guess that's why indoor restaurants are a little down the road, because you've got several people sitting at a table, they're close, they're sitting together for a while, and that's where you have the issues.
Exactly.
Wearing the face mask, washing the hands frequently. Yeah,
face mask, hand washing.
And physical distancing.
And the physical distancing. Those continue to be the principles.
Well, hopefully everyone's going to continue these measures so that we can take care of this thing for the long run. We know it's going to be around for a little while yet, but we want to try to keep it at bay. And again, congratulations to Peninsula Regional Medical Center staff. It sounds really impressive that you were able to just really get ahead of this thing and keep the cases low, keep the mortality rate low. Just a gem for the community. And I thank you so much for coming in again. When you've talked about several other topics, but now this is a very timely one. And as usual, always full of important information.
Great. Thanks very much again for having me.
And thank you for joining us for this edition of Focus on Health here on PAC 14.